wish you all a very warm welcome and thank you for joining us. My name's Adrienne Crowder. I work with the Wellington Guelph Drug Strategy, and my job today is to be the facilitator for our session. This is the last of a three-part training series that we designed to meet the needs of frontline workers who support people who are using crystal meth. And I'd really like to thank Stonehenge Therapeutic Community, who gave us the funds to offer these trainings, and also a shout out to Nick Boyce at the Ontario Harm Reduction Network and Janet Stevenson from St. Stephen's House, who helped us put the content together. Information for you, we are recording the sessions and they will be available on the Wellington Guelph Drug Strategy website as of December the 15th. Just to put today's session into a little bit of context, for some of you may have been with us for the last two sessions, but our series started with Dr. Tim Guimond, and he was speaking about how crystal meth impacts brain function and behavior. He provided us with information on the neurotransmitters that are impacted by using meth, and he gave us some great case examples. And then our second session last week was presented by Sanda Kazazik, and she gave us some excellent information to guide how we can be more helpful in our interactions with people who are experiencing psychosis or any other adverse effects related to their crystal meth use. Today, our session is called Promising Practices. We're going to learn some more about supportive approaches for people who use meth. First, by learning how services can change the ways that they work to better meet the needs of their clients. And then we'll explore some practical and on-the-ground strategies to address the complexity of methamphetamine use disorder. So we have two presentations coming for you. After each presentation, each presenter, there'll be a little bit of time to ask some clarifying questions. We will ask that you hold big, more complex questions for the Q&A that will be at the end of the two presentations. Please send any comments or questions via the chat function. That's the chat's being monitored, so your questions will be picked up. And we'll also probably be muting mics during the session just so our speakers can have some clarity. So really excited that we're going to move right to what you guys came to hear, and that is our speakers. So the first presentation is called Nothing About Us Without Us, including the service user's voice. Our speakers today come from the Neighbourhood group and the Toronto Drop-In Network, who've been pioneers in this work. So today, Janet and Brian are joining us from the Neighbourhood group. The Neighbourhood group is a vibrant multi-service agency in Toronto, which provides a wide range of programs and services to create opportunities to improve and enhance people's lives and to help them live independently and with dignity. The Urban Health and Homelessness Services Department promotes the health and well-being of individuals living with substance use and mental health. And it does that by challenging stigma, advocating for change, and providing responsive community services. So thank you, Janet and Brian. And then we also are joined by Diana McNally from the Toronto Drop-In Network, which is a member-based organization comprised of 51 drop-in centers throughout the city of Toronto. It works towards a socially just Toronto, which is safe, healthy, and inclusive, through enhancing the capacity of the network of drop-in centers to improve the quality of life of the people who participate in their service. So thank you very much. And I think we're going to hand things over to Janet to start us up.
Great. Thanks, Adrienne. I'm going to share my screen. Whoops. I have to hit share screen first. Share from the beginning. Okay. All right. So hi, everyone. My name is Janet Stevenson. I'm the Senior Manager in the Urban Health and Homelessness Services Department at the Neighbourhood Group, formerly St. Stephen's Community House. We merged in April, so perfect timing with COVID to do a merge. And we are now the Neighbourhood Group. So I'm going to speak first, and then Brian is going to join into the conversation. So without further ado, so in 2016, us at St. Stephen's and our partners noted a real dramatic escalation in the impacts of crystal meth use among our service population. And that includes things like an increase in social isolation, homelessness, very much impacting the complexity and worsening conditions around physical and mental health, increased contacts with the criminal justice system, more barriers and restrictions. Often people were restricted from most places in the city, and as well as violence, stigma, and discrimination. And that was being experienced in the community as well as in institutions, often being experienced when going to hospital, as well as very tragic in the loss and death as a result of overdose and other things. So when we recognized this, we really wanted to do something quick. We realized we had to. So we created an internal crystal meth task force, for lack of a different term. We weren't very creative at the time. And it was just a group of staff internally who came together to really have some time to focus and think about our next steps and come up with a strategy. So at the center of everything we do within the Urban Health and Homelessness Services Department, we really keep the service user at the center of that. And we quickly realized that what we were doing wasn't working. It's not meeting the needs of the folks that we serve, and we needed to do something different. It's not up to the folks we serve to adjust to how our programs were running. We needed to make some adjustments to our programs to better serve folks. So this required us to be really nimble and flexible. And just, with recognition that we have no dedicated resources, to be able to look at what programs and services we have to be able to adjust those to better meet the needs of the folks we were serving. So first and foremost was we needed to connect with people to find out what they needed, to gain understanding and feedback and perspective from them as to things that they wanted to see happen to better support them. Some of those things we were able to implement quickly without dedicated resources. Some things we weren't. One of our major programs within our department is a drop-in service, and that sees about 250 people a day. It's a very busy, outside of COVID. Right now we do see far less in the space, but usually we see about 250 people a day, and obviously it's a very dynamic environment that can be very stimulating. So a lot of people wanted to have a more quiet drop-in space. That requires resources to do that. But we needed to think about what we can do within the resources that we have. So we started building our strategy from there. And these are just a few of the things that did get implemented from that multi-pronged strategy. So one was, we called it the AMP group. That came from the group of participants. And it really was a group, it's run by a peer with lived experience. We pay people who attend it with an honoraria. And it's an opportunity to provide really practical harm reduction focused strategies, as well as an opportunity for us to receive feedback and ideas about program and services. It's casual, you can drop in, you don't need to sign up ahead of time. And it's just a real space that creates a sense of community. It's meaningful use of time. Sometimes they do things like, kit making and stuff like that during it. Other times it's just about chatting and connecting. And as I said, it is facilitated just so that we can ensure, that the group remains within focus. We also created a bike workshop. This was in partnership with a local bike company. We are located out of the Kensington Market community in Toronto. And so there's lots of local bike businesses and a thriving bike community. And folks we were working with really enjoyed tinkering with bikes, taking them apart, putting them back together. So with that, we were able to use our drop-in space in the afternoons when it's closed, to be able to create a really low barrier access point for people to come in, engage in something that's really meaningful for them, while at the same time we're building connection. And that often can lead to engaging with our other programs and services across the department, as well as externally to us. So through an engagement point, we were able to then move that forward to engage with folks in other ways. We also work with a physician who runs a primary care clinic on site, and he was able to start offering some trial replacement therapies. So this was, very much trial and came with several barriers, but nonetheless, we wanted to try. And so this was a way of trialing that piece while also combining it with other supports, including Could be case management, drop-in supports, housing support, employment supports, any number of things that people may want based on their self-determined goals. And then that is with our interprofessional supports across the department. So we do have, we have peer outreach through, again, we have no dedicated resources for any of this. So it was looking at what peer outreach we have and being able to leverage that to do outreach in the community to connect with folks who may not be already connected with us, being able to bring them into our programs and services, build those relationships, and then connect them with whatever in-house supports we can, as well as obviously liaising and connecting them with supports otherwise in the community. Capacity building was a big piece. This is very much intertwined with stigma and discrimination that folks were experiencing and continue to experience. So we were able to create some very much focused crystal math education series. This came in a 5-part webinar. And this was done with staff and several folks with lived experience to create the content as well as create the actual webinars to then be able to have them go public so that people can access them. We've done several trainings. We do various print materials, any number of things where we can increase that capacity and awareness and decrease the stigma and discrimination. So these are links to the webinars. They can be found through our website as well as on our YouTube channel. And they're free, they're short. I would encourage everyone to check them out if you haven't already. And those webinars, we did receive a small pocket of funding. It was it was 6 months. That was it. There was no extension to it. So that was we were able to do some of these strategies, but without further funding, there's things that we're not able to sustain. So we're always continuing to seek further opportunities for funding so that we can continue to build and fulfill our robust strategy. So now I am going to invite Brian to jump in and provide some insight and expertise.
Awesome. Can everyone see me or hear me or something? Everyone hear me? Yeah, awesome. Cool. So hi everybody, my name is Brian. I am a service user of Neighbourhood group. So my history is with just so let's background for me. I'm sorry, I'm a little bit nervous because I was just like I'm not too sure like how I'm supposed to incorporate myself in this. So I'm one of the service users at the Neighbourhood group. So I'm a substance user. I do currently actively need news, and for me like one of the important parts is to be part of the community again. So a bit of background for me is I started using back in 2017. So one of the things that I found when I was first started using is that I have a lot of history with therapy. I have a background with harm reduction services. I have a lot of background with like reaching out to people and providing services like these. But I'm still susceptible to the pitfalls and the addiction of the substance. So for me, like one of the critical points is that it was so important for me to sort of like get out of the isolation. One of the things I found was that like the news was starting to make me more anxiety ridden, started to make me more like closed off from services and closed off from like workplaces that I used to go to a lot. And for me, like that made me more susceptible to like using, and I became sort of engrossed in the idea that like I didn't really like, even though I understood like what was happening with me, I didn't really apply it to myself. Like becoming a service provider to becoming a service user was very scary for me. So one of the things I've noticed is that over the years and stuff like that, I started to become more, my news started to level out and things like that. I started to remember like to go back to my trainings. And one of the things I found really important was accessing services again. So when I became homeless a year ago today. So this is really it is a year ago today. A year ago today, I became homeless, and for me, like that was a really big shock. I didn't really know how to like navigate the system. I didn't really know how to like access services, even though I was providing those things. So when I finally did become a part of the system, a lot of things sort of fell into place. there was a lot of talk with myself about like trying to um, reincorporate myself into the community, but also reach out in some way. So for me, like when I became homeless and when I first started accessing services, one of the critical points was sort of this outreach that the neighborhood group did with my current place of residence. So I currently live at the Five House transitional housing, and even though I'm an active user, like there's such a non-judgmental and sort of like safe space for me to share about myself and stuff like that, that I'm able to sort of still slowly ease myself back into it, build up the confidence again to sort of access services, to reach out. So one of the things I always found really important with harm reduction is just knowing what harm reduction is. So like having the ability to sort of talk with people. Like I'm part of the training program here at the Neighborhood group, which is the peer support training, and I have a placement now. So for me, like that's crucial for me, because right now, like I'm going from a place of anxiety ridden, nervous, and like not sure what to do, to like now slowly incorporating myself into like learning, reintegrating myself into society, um, accessing services that are, benefit me and also build up my skills, and also allows me to sort of have a voice. And that's one of the most important things I found when it came to these sort of to doing this. Like just me talking to everyone here right now is like nerve-wracking for me, but it's also really important for me because I want everyone to know that like these opportunities really mean a lot, because they also help me build up my confidence, help me build up um, my ability to sort of take care of myself and to self-care, to have that self-advocacy, and to actually be aware that like, hey, just because I'm a active user, or just because I have a background and stuff like that, um, it's really important that I have these sort of things, because it creates a sense of community, creates a sense of confidence. Thank you so much, everybody, for the words of encouragement. And yeah, it definitely is. It's helping. It's me helping myself, but also helping the people around me. Because I care about, like, just because I used substances back in the day just to like cope with things and stuff like that, and knowing that um, being able to sort of have a space in which I can share that sort of history and share that sort of uh, a context with people allows me to sort of open up, and also become aware, like, oh, I am not my disorder, I am not my addiction, and things like that. Um, being aware that there are compassionate folks out there who want to listen to the service user, who want to listen to us about, like, oh, we're real people too. Like we have a voice. We could be anybody. Like I used to be an HIV coordinator for like 5 years at Asian Community Aid Services, and like now I'm homeless in the building, but like I still feel empowered. I still feel like, oh, there is still opportunities for me out here. There's like folks, like there's opportunities like this, for instance, that allow me to there are opportunities for me like this, for instance, to be like, hey, this is how my mental health is, this is how I'm feeling, this is how I experience this. And like what's awesome is that like I'm just one voice. When I have the empowerment, like when I share this with people and stuff like that, they are like, oh yeah, I have that. They can also tap into the feelings of it, because it's not just for me, it's not just about, oh, that story doesn't match me. It's more about the feelings behind it, like the feelings of loss, like hopelessness, of loss, of like trauma, of anxiety, of like fear, of like, why do I use, or like what can help me get better, what can help me get stronger, what can help me be more confident. And it's these sort of services, these sort of like incorporations of um like asking like the users and stuff like that, like, what do you need? And we just need a place where we can be heard. We need a place where we can be confident that our experiences are validated. We need a resource, or a space in which we are able to sort of um, build, dedicate, and motivate ourselves, and also have the encouragement of others around us, because we can't support ourselves 100% all the time. We can't support ourselves, like we can't, like, it's nerve-wracking to do that. So having the space like Neighborhood group, or having spaces where we're able to sort of like voice our opinions and have them heard and incorporated, is so important, because then we can feel like, oh, even though I can't support myself 100%, even if I'm at like 70%, 60%, folks like you folks are able to help support us like that 20%, that 30% more, so that we can build up that encouragement again. We can understand what harm reduction is. We can understand like how to better help our own communities. We can feel like we're integrated and we can feel meaningful again. And then like we don't feel like we're just, you know, a statistic. And having that sort of encouragement, having that sort of empowerment is crucial, because look at me, I'm here talking to you folks right now. Like if you were to ask me if I was going to do this like a year ago, and like a year ago I would have been like, heck no. But because of the motivation, because of the encouragement that I've had over the past 6 months or so, with the trainings, with peer trainings, with having the peer supports and stuff like that, it has helped me sort of, you know, been like, okay, yeah, no, I would totally love to talk to people about this, because it's so important. It's crucial for us to have a space in which we can openly discuss stuff. And I love how like I have a little kind of unicorn back there. It's like we're like, we don't have to feel isolated. I don't have to feel isolated. I don't have to feel alone. I have people checking up on me, like both here at Five House, but also through the staff at Neighborhood Group. I have my peers checking up on me, being like, hey, we didn't see you at we didn't get you at the workshop last time. Like, what's up? Like, how's it going? And having that sort of accountability, but also having that sort of like feelings of actual like support and care is so important, because it's just like I don't feel isolated. I don't have to, you know, sit in my room by myself and like muse, or like I don't have to like wallow in my own anxiety and like the monsters that come up with when it comes to crystal meth, because that stuff can get very, very dark very quickly. But it's because I have the supports, because I have like people like Janet checking up on me, and like, you know, I have like people treating me like a normal person, that I can still feel like I still am a normal person. And knowing that, and you know, being able to be here and sharing that, like I get my voice to be heard. I can get my voice to be a voice maybe for other people who aren't as um, who aren't as supported, or who aren't as, you know, who have fallen through the cracks. Because, you know, one of the things that's important about me is that because I'm like, because I'm a peer, because I'm also maybe still actively going out and doing stuff, I can still reach those people who aren't as confident, who aren't as, you know, willing to access services, so that I can still like be like, hey, you know, I can share the knowledge I've accumulated with them as well. Exactly, I can show them the way, or I can be like a guiding light, in the sense that like I can be a bright light in which they can follow, even though they don't want to follow like the other, like, you know, huge ass bright lights. But I can still be a place of refuge. I can be a place of like I can still be like a place of like harm reduction strategies and things like that. So it's really important for me, at least, to have access to these services, but also to be a part of these services, because it helps increase my own knowledge, but also helps me share knowledge as well. So yeah. I think that pretty much covered it. Yeah, so I wanted to thank Janet as well for like allowing me to be here, because I've been I'm still very new to the neighborhood group, but I've been having such an amazing experience with the peer support group and peer support training, that I'm thankfully, yay, I did my placement interview today, so I'll be having a placement with the neighborhood group as well, to like, you know, to further my foray back into the community. And I'll be able to sort of I'll still be able to share my story, but also to be able to elicit more support from others, but also to share my support, to share the experiences I've had, but also to share sort of the inspiration, the drive, the care, the love that I've felt here. And I really hope, you know, that you've all taken if you all take a piece from one piece from this, is please give us a voice. Please give us space in which we can voice ourselves. Encourage us to share, encourage us to like be who we are, and allow us a space to like remember how important we are to ourselves, and how important we are to our community, because that's one of the crucial points. We are important. We all are crucial. We all are cared for. We all are loved. And thank you, everybody. And that's my portion.
Thank you, Brian. And we're lucky to have you at the neighborhood group, and I can't wait for you to start your placement.
Yeah,
I
thank
am
you.
going to share my screen again and hand it over to Diana.
Diana, can you unmute, please? We aren't hearing you. Thank you.
My bad. Sorry, I was just saying I don't know how to follow up after that. But please partake of this spiel that I'm going to give you. So I come from the Toronto Drop-In Network, and as was mentioned, we are a network of about 51 organizations across the city of Toronto that operate drop-in centers, which includes the Neighbourhood group. And in fact, they are our trustee. So that is partly why we have this connection. And I'm going to speak kind of more to, in a general way, how to prepare your organization to even create programs that are meaningful and inclusive for people who are using crystal meth. If you go forward a little bit. Next slide. Next slide. So I'm going to kind of focus on team practices first, and just to kind of highlight what some of the precursors are to actually working well with people. I think it's really important that we're very intentional in how we kind of create the avenues for people to actually be involved in our organizations and for them to be involved in program design as well as program delivery. So when the Neighbourhood group says nothing about us without us, I really want to kind of articulate that in almost a step-by-step way, because if we aren't intentional about this, we can actually kind of create harms for people. So we have to kind of create an environment in which everyone on our staff team, the organization as a whole, is actually on board with what is actually happening. If we don't have that, if we have divisions, it can be extremely problematic. Next slide. So I'm posing these as questions, but I'm not going to open it up as a question, so I'm just going to speak to them. So one thing that I think is really important for all organizations to do is actually perform check-ins at the beginning of a shift. I know from working frontline in a number of different drop-ins across Toronto is that we often do check-ins, but one thing that we don't do is actually check in with one another about how we're feeling that day and what our capacity is. We tend to check in around participants who are coming to our programs, major events that may have happened, programs that we're running that day, but we don't actually interact with one another as staff to ask, how are you doing? And so we know that when we're working with folks who use meth, and my capacity, I'm working with folks who sometimes are in meth-induced psychosis when they're coming into the drop-in. And if my capacity is really low, I don't have the time and calm and patience necessarily on that day, or even for a short period of time, to really provide fulsome support to someone that isn't going to potentially kind of change into a situation where I might actually be causing harm if I'm not really kind of at my full capacity. So we know, again, that folks who are, who are using meth, again, can be working with folks sometimes throughout the entire day. Sometimes, if you're running a 24-hour facility, it can be over a few days. So we do need to have a lot of patience, and the check-in part and the capacity building within the team is really important. Okay, next slide. Sharing the work is also clearly very important. As a team, is your practice both current and is it consistently applied? If we have certain folks who have training in some, things and others who don't, are we sharing that knowledge across the team and implementing that as a common practice or understanding? If we don't have that kind of shared understanding, you may have some staff who are kind of, I don't want to say overburdened, but there's more focus on them to provide supports to people that unfortunately are deemed by some as being difficult to serve, which is a term that I really hate. But I recognize that if we don't have that common understanding and that capacity across the staff team, that there will be some staff who folks will gravitate toward and other staff who aren't really engaging with those folks. So we kind of need to create a more consistent approach and to have difficult conversations about what is the vision of our services? What are our goals? What are our practices? What are the processes that we have in place? And really, this is kind of a piece for management, is to create space for those conversations, which sometimes can be really difficult because we all have to acknowledge that we have biases, and everyone on every staff team everywhere does inhabit some biases within them. But we have to take time to actually hash that out, which isn't easy, and I totally understand that. But if we don't do that, again, you can have these real disparities in how people are working with folks who are coming into your space. Okay, next slide. Building community understanding is also a really key piece and something that organizations should really work toward in order to actually lay the groundwork for creating meaningful programs. I know from working frontline again, I worked at the Meeting Place, which is a drop-in center at Queen and Bathurst for about 3 years. I worked at Park, I worked at Sistering, Christie Ossington Neighbourhood Center. I currently work at All Saints, so I have a lot of experience working frontline in drop-ins, and for the most part, largely actual low barrier drop-ins, not just drop-ins claiming to be low barrier. But it's important for me to take the time to really kind of actually point out when other community members are supporting one another. And in fact, we know that participants who are coming into our space, outside of our space, inside of our space, they're doing a lot of the legwork to provide support to one another. And that is absolutely community work, but we don't recognize it as such. And I think it's really important to take the time to recognize when people are treating each other in a support fashion, with compassion, and not just, to take them aside and be like, really good job there, but really to kind of emphasize to the broader community, like, you did a really wonderful thing there when you're supporting that person. Like, it was like, I really want to thank you for that, that work that you were doing. And even if we're not doing that kind of just as an open conversation, if you have tools built into your space, maybe you have a town hall. One thing that I used to do was kind of have like member of the week. So member being a drop-in participant coming into space, and I would take the time to highlight someone who was actually doing something really amazing for their community, whether that was providing really great support to someone or doing something like cooking a small community meal for folks. It's a way of actually acknowledging the almost secret work, the unacknowledged work of people coming into our space. And it creates better community understanding so that, if folks are in meth-induced psychosis, for example, and we take the time to actually point out when folks are working well with them, that can help to create a better understanding within the broader community of what working well with someone really looks like. Okay, next. This is kind of the key point of all of this. And I think, Janet was speaking to this quite a bit, and also Brian, obviously. We need to really engage service users in the design and implementation of our services. We need to stop with this kind of top-down approach. And I know there are caveats to that, because sometimes, program design comes from the funders, and that comes, down, and you have to build the program according to their rubric of what this needs to be. But we need to really be intentional again in kind of gaining the feedback from people who are using our services. And that can be informal, that can just be having check-ins and chats with people, or it can be formalized. And so with the neighborhood group, they have the AMP program. And although that's kind of a drop in space, that's a formalized way of gathering feedback from service users that is then utilized to actually create further programming. So something like that, like having a focus group or a drop-in group, a town hall again, suggestion boxes, individual check-ins, it's really important to have those in place. And to have multiple ways of engagement in place. So not just one kind of tool that you're using, but to allow as much possibility for people to actually get involved in kind of giving you feedback on your services as possible, and taking that seriously. Next slide. Okay, so I'm gonna try and blast through these a little bit because I think the team practices are a bit more important, and I recognize that we're a bit short on time, but next slide. We're gonna talk about individual practices. So, I mean, as community workers, as healthcare workers, practicing self-awareness should be part and parcel of what we do. But I think it's really important to understand if your capacity really isn't there that day or in that moment, you need to be aware of when your interactions are way more about your needs than they are about the person that you're working with. And so if we actually do create, an environment in our staff team where there is a lot of sharing of the work and a common approach to the work, you can tap out. If it's about you need to step away anyway, because again, you can potentially cause harm to that person, and tap in a coworker who potentially has more capacity in that moment to work with somebody. Okay, next slide. Patience. You need a lot of patience. Generally, you need a lot of patience, but really working with folks who use meth, again, there's been times when I was working evenings and overnight, sometimes assisting. I finished my shift, come back 24 hours later, and someone was still kind of in the same mode. So when we talk about practicing patience, I mean, this can take sometimes quite a bit of time, but I think it's important to be able to stay calm and cool and patient with people and to not rush them. And again, not make it about you, but to ensure that their needs are being met. So you need to be calm, you need to be non-judgmental, you need to be respectful, frankly, with anyone you're working with, not just folks who are using meth, but that needs to be kind of the foundations of how you're engaging with people. Now, that said, it's like, yes, you have to be patient. Yes, it can take a lot of time, but if there is an incident, something escalates because we're not being patient, we're not being supportive, if an incident occurs, the amount of time it takes to rebuild a relationship with somebody is astronomical sometimes. Sometimes you can never really rebuild that relationship, whether that's between an individual staff person and a particular participant, or a participant and your services, or services overall. So let's say there's an incident and it results in a service restriction, which we always want to minimize that. In my personal practice, I don't engage in service restrictions at all. The amount of time it would take to make someone or rebuild that trust, mutual trust between you, could take months, years, and again, sometimes never. And if they start to mistrust your services or services overall, that's deeply problematic because it obviously leaves them without a lot of their basic needs being met. So, we want to make sure that the patience isn't just about what happens in that moment. It's about curbing this potential break in a relationship between a person and, a staff person, an organization, or just services in a broad way. Next slide. With anything, you can never assume what anyone needs. So I can't assume what someone needs in the moment. If we're working with someone, we want to take their lead and we want to provide support accordingly. One thing, if you're engaging with folks, don't ask too many questions. It's really annoying and actually can be quite triggering. So there's not a lot of tolerance necessarily for intensive questioning, but if we're working with folks, just kind of follow along with what they're doing and, be minimal in how you're actually asking, like, is this what you need? Or if you're asking for clarification of any kind. Next slide. Never say no. Frankly, no one likes to hear the word no because it shuts you down pretty much immediately. And it can also really escalate a situation if there is indeed a situation, but just generally, even if someone's just asking you for something and you say, like, nah, I don't have that, that's irritating at the very least. So we want to be able to provide alternatives instead. And I recognize that, especially in social services, we're not, like loaded up with resources, and some things that people are asking for, we can't, necessarily provide, but there are things that we can offer. So, being mindful about offering people alternatives instead of saying, like, no, I can't do that, I think is really key to working well with people. Okay, next slide. We also know that, if someone especially is in meth-induced psychosis, they're feeling a lot of fear, they can be feeling a lot of suspicion, and that can present outwardly to some as aggression. But aggression isn't the issue. It's not an issue. What the issue is that someone is feeling afraid. And if they're feeling afraid, they're feeling vulnerable. They are vulnerable. And so, there's this fight or this flight response, and what you're seeing is the fight response. But don't address the actions. Let's say like someone is like punching in a wall. If it's not load bearing, it's not a big deal, really. So ultimately, if we address why someone is feeling afraid, because that can underlie the aggression, then the perceived aggression will go away. So definitely when you're working with people, you don't want to be like, stop doing that. You definitely kind of want to be like checking in about how they're feeling, because that will kind of allow people to kind of calm down. And if you especially have a good relationship with that person, they'll be more willing to kind of just like have a chat with you about what's going on. Okay, next slide. You can also walk people through experiences. So if someone has shared with you, what's going on with them, maybe when they're in meth-induced psychosis, for example, you can share back with them some common patterns, what to expect. etc. And so that can also help to kind of address people's fear or suspicion in the moment. When you reflect back, like, remember when, you're feeling like this last time, and then we chatted afterward and you said, it was like this, or I found this helpful. You can reflect back that information to them so that it can reduce their fear again. Okay, next slide. Be aware of your body language. So definitely, you want to communicate. You don't want to be an academic and just start spewing, all these kind of large words and be really verbose. That's, again, annoying for most people, quite frankly. And you don't want to be moving too quickly, move slow, be calm. Mirroring is a funny one because sometimes it can look a little bit not right. So, you want to mirror the body language insofar as someone is sitting down, you sit down with them. If they're like pacing around your space, walk with them and just check in while you're doing it. Okay, next slide. Don't have your phone out. This is one that really bothers me in general because it's like, I have here in a drop-in because, again, that's my context. But if you are, working frontline, it's like, why are you just like boop, 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 boop? It shows to others that you don't really care about what's going on with them. And on top of that, technology can actually be quite triggering for folks. So we want to kind of minimize having, our phones out in space because technology, especially for street-involved people, is associated with surveillance, which is associated with criminalization. Okay, next slide. Okay, give people space, don't crowd them. I realize I'm running out of time. Next slide, next slide. Okay, if you are building programs with people, there are some practical things that you should have in place. Snacks, always, because folks who may be using meth, especially prolonged usage over a short period of time, they're not eating necessarily. They forget to eat. They forget that they're hungry. They're not actually ingesting liquids. So good things to have are soft foods like hard-boiled eggs, yogurt, milk, juice, chocolate milk is the best, and freezies. And all of these things in different degrees can actually kind of address, nutrition, hydration, and, sugar cravings that people might have at the time. So they're really great just harm reduction tools in general, and you should have something in place in your program. And freezies are a good one because they're wildly inexpensive and pretty much anyone can afford to buy at least some and keep them in their freezer in the organization. Okay, next slide. Activities to engage people's wakefulness. So, Janet was alluding to the bike program that was at the Neighbourhood group. Yes, that's okay. You can go for it. It's okay. Next slide. It's okay. I, for whatever reason, my background is in art and art history. And so it's completely unrelated to what I'm doing now, but not exactly. So when I was working at the meeting place, I was running two peer programs. So one was the eviction prevention extreme clean program, and the other was the meeting place storefront, which is right at the corner of Queen Bathurst, and people can go in and buy things. And the idea behind the storefront is that, members can create amazing artworks or crafts and put them in the storefront on consignment. And if they're sold, they keep 100% of the profits. So there was one fellow that I was working with, and he actually comes to the Neighbourhood group pretty much like every other day or so. So he's a common face there as well, but he was coming to my drop-in at Queen and Bathurst. And he's someone that was service restricted a lot. And generally on the basis of his being a person who uses meth. And so he would often be yelling, being very loud, but it was a way of creating space around him so that he could feel safe. But when he was doing better, he would do a lot of drawing and artwork. You'd just be like rolling his weed and also kind of just like scribbling on things. And I was like, your work is actually it's really amazing. And so, it was kind of like, well, what can we do with this and kind of harness that wakefulness and that energy and that focus in a way that is like beneficial for him. And so I had all these donated purses and I got some markers and I was like, let's just start decorating these things. And so this is something that he made. It was a donated purse again. He was using markers and he made this super cool purse and actually a bunch of them. And we were able to sell all of them for between $20 and $50 each. So it was a way of kind of soothing him and giving him an activity that he could focus on that would also provide him with the mutual benefit of having, kind of this financial reward. So that energy can be harnessed in a lot of ways. And I think it really depends on what someone likes to do, what they are doing, kind of being observant of, like, are they fixing bikes outside, or are they always doodling? And then creating, kind of pathways for them that kind of build confidence, but also demonstrate that they are absolutely able to be engaged in like saleable stuff. And I think that's all I really had to say. And I'm sorry I rushed so much. I had too many slides. I'm done.
All right, thank you very, very, very much. So Diana and Brian and Janet, that was amazing. And you're really showing us how you change services from transactional and interactional role-based services to real communities and places where people are supported and they can grow. And Brian, I think you used the word love. I would put that in there too, where people can feel love and be loved and come back to their wholeness. So thank you. That was just awesome. Olivia, do we have any questions to share before we move on to our second presentation?
No, just lots of encouragement. And
Okay.
Janet and Diana's emails are in the chat if anyone wants to
Awesome.
contact them after.
Awesome. Well, just many, many thanks. That was inspiring. So I really appreciate your sharing your words, and great big thank you to you. And so I'm excited. We're going to move on to our second presentation, and it is called Psychosis is Psychosis. And our presenter is Gayle Parker, and I'm going to just share a little information about Gayle. She graduated in 1989 with her BSN from Bachelor of Science in Nursing from McMaster University, and she's worked in the field of mental health nursing since graduation, practicing in direct patient care in both hospitals and the community, and also working in management, teaching, and research for McMaster. She's published papers on the quality of life, cognition, and diabetes as it relates to people with schizophrenia. The accomplishments that she's most proud of include launching People in Motion, a novel healthy lifestyle program for people living with mental illness in Waterloo Region, raising 3 kids to adulthood, and becoming a nurse practitioner in 2016. And currently, Gayle provides primary and mental health care to people who are homeless and marginally housed in Kitchener-Waterloo. So really appreciating that we have Gayle with us today, and I'm just going to hand it over to you.
Okay. Good. All right. Can everyone see my screen then? Yeah.
It's all good. If we can just put it into, from the beginning, then we can get slide by slide. Thank you, Gayle.
Okay. Did I? All right. So it's working okay now? Yeah. Okay. All right. So today, what I was hoping to talk to you about is to just help you learn what you can do when someone presents to you with crystal meth addiction, to understand that that this addiction is really complex and has a lot of comorbidities, and to have more familiarity and to feel more comfortable about psychosis and how to respond. And last of all is to hold the hope. I think that's one of the most important things that we can do is hold hope for people when they're at their weakest moments, they're not knowing where to go, and they turn to you. That you can feel that yes, I can help you here. So this presentation is kind of based on my experience. I have some guidelines, none of them are Canadian, that are based on for crystal meth addiction. And I don't have any disclosures to report because I'm not getting any funding from any pharmaceutical companies. Mm-hmm. So to kind of start, I want you to meet Tom. So I met Tom almost 3 years ago when I just first started working at the Working Center. He was sitting outside my clinic doors on a February 3 years ago, and he said to me, help me get off the meth. He's 34, male, single, homeless, First Nations man. And I thought, great, this is wonderful. Here's somebody who has reached out and wants to, wants to help. And this is really honoring when people reach out to us, and we really need to respect that. So I thought, this is a no-brainer. I'll just, help him call detox services. We'll get him into detox. Then from there, he can get into a treatment program, get into addiction housing. And, it's just going to be all this seamless service. And I quickly realized how broken our system is, and how it doesn't work like that. But working with Tom has helped me learn a lot, and also helped me hold the hope and help others as well. So to start with, I always use, and I recommend that you use a trauma-informed practice. What that is right now during COVID, we hear a lot about, having people use universal precautions, right? You wear a mask, you don't know who's going to be infected, that kind of thing. So you practice good hand washing. And that's the same kind of approach we use as with the trauma-informed practice, is we assume that everybody who comes that we meet has been affected by trauma. And so we have, an approach that takes into that and the gentleness and the understanding that comes with that. So my favorite resource for this comes from the Clinic Community Health Center. I also have that at the back of the presentation, but it's a really great comprehensive Canadian resource on trauma. But essentially what it is I ask before I do anything. I even ask before I ask. And really the basis is to really think through how to do no harm. Even if we think we know what's best about their health, we will do harm if we don't ask first what they think is best about their health. The other thing that I kind of keep in mind as for a background is recognizing that there's the 5 A's of addiction: ask, assess, advise, assist, and arrange. Again, this feeds back to the trauma-informed approach. Always start with ask. It's the most important way to start. It shows respect for the person's life and why they've made the choices that they've made. And it recognizes that we're the guides, they're the drivers. So our goal is to ask questions, listen to the answers, and then this is this is what will guide where we go next. And to me, it's a whole lot less overwhelming. If I see someone and I think, oh my goodness, like they're homeless and they have this addiction and this, and then they've lost this and that, and I put forward all these problems to myself, I get very quickly overwhelmed. But when they come and I start with where they want and we work through those things, it is much more not only empowering for them, but a lot less overwhelming for me. After ask, and sometimes I don't get through ask. Sometimes ask, we sit with that for a couple of sessions, right? But after ask is assess. Why are you trying to, and what we're trying to do is to determine why now. What are the reasons to change? Have they ever been in this point in their life before? What did they do? What worked for them? What didn't work? Why do they use the drug that they use? What does it do for them? What are the benefits of the drug? What do they find that they don't like about it? And why we need to really go through this whole assess is there is not one single proven scientific way to overcome crystal meth addiction. After assess would be advise. And lots of times I don't get to this. Again, a lot of times I don't have to. After we do the ask, we do the assess, the person themselves says, you know what, I think I'm going to go and do such and such. Again, that keeps them in the driver's seat, and we go from there. The most important thing when I'm trying to do no harm is to realize, like, I need to build rapport. Why would someone come to me? Why would they seek my help? Uh, you know, this is not a quick fix solution that's going to happen in a single session, and we're going to journey with this together. And they need to decide that they want me in their car with them. They want to travel with me. And they need to feel respected and not shamed. And for some people, they can figure that out right away. For others, it might take several sessions. Now I wanted to just kind of dive into talking about the whole comorbidity of meth addiction and how it's so multifaceted. These also give us knowing all of this also gives us lots of room for how we can help, depending on where the person wants their help. So PTSD is a risk factor for developing any addiction. Because the substances are used to numb that profound pain and suffering. And again, that's all part of the reason why I try to use a trauma-informed practice. Homelessness. Our economic policies have created a housing crisis. Our healthcare funding doesn't adequately support mental illness. We've been underfunded in mental health for decades. And our system doesn't support complexity. And this is, a very complex addiction that our healthcare system hasn't even tuned in that they need to recognize it. Psychosis, and I'm going to spend some more time on this as well. But meth use is associated with 3 times greater likelihood that people will use psychosis. And half the people who use meth have experienced psychosis prior to use. So what we end up with is not really knowing what comes first, the chicken or the egg. And this kind of goes back to my title, Psychosis is Psychosis. I was really frustrated when I first started in this work because, somebody would present at the Emerge and in quite a psychotic state. They're really scared. And, they would test their urine, see that there was meth in their urine and send them off, tell them to stop using meth and send them off. And not even trying to recognize, is there an underlying illness here? And is the meth use superimposed on this? What is happening? They would, they'd give them some medications to calm them down and then send them out the door. Not, again, recognizing that the antipsychotics or the medications that they've given them has now helped them. And so they're just saying, well, see, you've been off meth for, 24 hours, you're fine. So and I'll keep talking about this more as as it goes on. Traumatic brain injury. Prolonged meth use can cause brain injury to the thinking, memory, and movement. But also, you can increase your risk of trauma, including brain injury, while you're intoxicated on meth. So because you feel you're invincible, that kind of thing. So traumatic brain injury is a common comorbidity. Skin lesions, people like to refer to them as meth mites or parasitosis. And it's very real. When I've researched this, meth is a crystal, and it breaks through the basement membrane of the vasculature system or our blood system, and goes into that intravascular area between the outside of the blood system into like underneath the skin, and that it feels like a bug. So and it's very uncomfortable. So there is a biological reason to why people feel like they've got bugs crawling underneath their skin. And when I let people know that, they really, so you believe me. Yes, I believe you. And then we can look at what we want to do about that. Tooth decay, gum disease. I hate the term meth mouth. Again, where that comes from is it dries out the saliva in the mouth. And then without the saliva, you don't have all that healthy bacteria and stuff that you need in your mouth. Also, to not forget that people may not just have meth as an addiction. They can also have other addictions as well. And we need to really be particular about a cross addiction with opioids, especially with our opioid epidemic that we have now. But there's also alcohol, tobacco. With it can also come infectious diseases, in particular, if people are injecting their crystal meth. There's heart disease. This is the second leading cause of death for people who use meth. It increases the blood pressure, it increases the heart rate, and it constricts blood vessels. Kidney disease, kidney damage as the body's trying to eliminate the drug. It can cause extreme weight loss. We always talk about having an obesity epidemic in Canada. Certainly not with people who are using meth. They do not have an obesity problem. Sleep issues, because it's used to keep you awake. There's some increased risk of Parkinson's disease. That's if people live long enough and live into older age. I've been having so many young people die. Yeah. And then adult ADHD. So I'm going to focus a little bit more on psychosis because this is probably the most distressing thing that and debilitating of all the symptoms. And just to kind of get back to what I was talking about earlier, when people go into the hospital, we have this spectrum of substance-induced psychosis. So when people are intoxicated, not everyone who is intoxicated on meth, experiences psychosis, but certainly some people do. Then you can have the whole substance-induced psychosis, where you use the crystal meth long enough and frequently enough that you can that your brain is now, even when you're not using the crystal meth and you're not intoxicated, you're still having the psychosis, to also having a full-on concurrent disorder. So I've been in this field long enough. When I was first in the late 80s, a lot of people had a concurrent disorder. So schizophrenia, and they used cannabis. So you now have an addiction and a psychiatric illness. That's what a concurrent disorder is, more than one. So it's not, so people who have schizophrenia or have bipolar, just because they have that doesn't mean that they don't also can have an addiction. I think some of our other presenters have talked about this. So what is psychosis? It's an impaired sense of reality. It's a disturbance in the senses. Your taste, your touch, your hearing, your sight, and also your smell. Beliefs that aren't shared by others, which we refer to as delusions, and they're called persecutory. I spelled that wrong, sorry. If they're sort of delusions where people are after you or out to harm you. There's paranoia, where you're suspicious, poor insight, not recognizing that this is related to substances or related to their illness. When I break an arm, I know my arm is broken. I can't use it. I need to have a cast. what happens when my brain is broken? And that part of my brain that tells me that my brain isn't working is the part that's broken. And that's the insight piece. They can have disorganized speech and behavior. So you can, the thoughts can ping pong all over the place, and they're not logical. They don't flow from one thought to the other. Could do, crazy things that you normally wouldn't do. Can be changes in mood. And there can also be thoughts of suicide and death. One of the things when we're thinking about and we're assessing for delusions, one of the things I want you to think about is when they're hearing voices, to find out a little bit more, what are those voices saying, and are those voices telling them to do things, and what things are they telling them to do? Because if the voices are telling them to jump in front of a bus, and they can't recognize that those voices aren't real, and they don't have that insight, we really need to jump on treatment, get them into hospital, that kind of thing. Those are called command hallucinations, and that's something important to explore further. How to assess for psychosis? Is this new? Is it long-standing? There's lots of people who live, who live happy, meaningful lives with some of the beliefs and things that they've been able to work around that, and they're still able to lead lives. Is it intermittent? Does it come? Is it continuous? Does it, when it gets worse, what are the triggers? Lots of times anxiety can trigger it. Again, intoxication with substances can trigger it. And also to look at physical illness. So is there a change? Is it increasing in incidence? Is it happening more often? Is it becoming more severe? And often things can be related to the route of use. So I believe Dr. Guimond spoke about that. If we're injecting versus inhaling, and also if there's a sleep deprivation to it. Again, how does it affect function? If people are still able to maintain their apartment, get their groceries, build meaningful lives, have meaningful activities, not so bad. But if they can't keep housing, if they can't, they can't find the how to feed themselves, they're not able to manage their money, their family and friends are all worried about them, then we need to act. And is there a change in their cognitive capacity? Is there a change in how they normally are thinking? All right. How to talk to someone with psychosis? First and foremost, there's no sense arguing with their reality. And I really find there's always a nugget of truth within the delusions or the hallucinations. And help to understand their reality and how that makes them feel. So that sounds like that would be pretty scary for you. What did you do about that? How can I help you? Also validate their feelings. A lot of times when they're telling you about this, you may not agree with their reality, but you certainly can agree with how it's making them feel. All of these things are helping you to try and find common ground, and listen to their cues. If somebody's telling you they need space, give them space. If they're telling you, I really need help, I need help now, you to jump in. So really kind of listen. When we're looking, how do we treat psychosis? And we treat psychosis with what we call an antipsychotic medication. Dr. Guimond spoke about how crystal meth, affects that dopamine system. So people are getting this surge in dopamine and also serotonin, and so that's so the antipsychotic medication kind of works on that, so that they're not getting that surge. There's some research coming out that it preserves those neurotoxic effects that can happen when your brain's constantly being bombarded with that dopamine and serotonin surge. But also to know that there is some controversy over whether it will increase meth use. I've not found that in my practice for people who are on antipsychotic meds and use crystal meth. But it certainly is, there's certain psychiatrists who just won't prescribe it if they think people are using crystal meth. Again, how do we treat psychosis? So the antipsychotic medications, we've got some really good tools in our toolbox right now. They can be given by mouth, orally, or we have what we call long-acting injections. One of them is every 2 weeks, a couple of them are monthly, and now we have one that's every 3 months. And how I try to help people figure that out is, are you the kind of person who can remember to take something every day? Or would you rather only have to remember to do something once a month? They are effective, but they all can come with side effects. Some of the side effects that can come with antipsychotic medications is it can cause weight gain, it can increase risk of diabetes, it can affect the rhythm of the heart. So we always like to do some screening labs, some lab work, and an EKG prior to starting the medications. And then every 6 months. Even if I do get people on antipsychotic meds, I don't stop there. We continue to work on their goals. We look at harm reduction, continue to assess their readiness for change, continue to look for changing drug use patterns, look at income support, getting people on from OW onto ODSP, and engaging with the community supports that the person might find helpful. We also want to look at treating the comorbidity, again, going back to that big list we had talked about. Do they have depression? If they're off their substances, are they experiencing post-acute withdrawal symptoms? Those can be treated with an antidepressant medication called an SSRI. And there's the literature saying one's not better than the other. So we've got a lot of different medications there to work from. Adult ADHD, we usually start with antidepressants that work on that norepinephrine or the noradrenergic system. And we usually use psychostimulants as a second line. They're a controlled substance. You need to do urine drug screens. They're at high risk for misuse or diversion. For people who are having problems with their sleep, mirtazapine is quite effective. And there's some beginning research that's looking at that mirtazapine can also help people affect the cravings of using crystal meth and wanting to get off crystal meth. And again, not to use benzodiazepines or anything like that to help them with their sleep. We want to, again, review everything at 6 months. When to stop antipsychotics. If the person stops using substances for a year and experiences no further psychotic symptoms, then we can start discussing tapering off the medications. I have not had anybody who's wanted to do this. Once they're been on their medications for about 6 months, they see what it's done for their lives, and so we'll also stop the medication if their side effects are worse than the cure. I tell people I don't want you to be on medications that you aren't finding helpful. I'll just wrap up here. what do we find? What have we found from people who we've been treating the psychosis with, the crystal meth psychosis? They're getting access to and maintaining safe housing. They're having less behavioral dysregulation, so less police involvement, fewer criminal charges, minimal to no jail time, fewer admissions to emerge. They're having improved access in relationship to their primary care provider. So if they have underlying infectious diseases like hepatitis C, they're making less ER visits and helping them get to rapid access treatments, methadone clinics, residential treatment. What the self-reported outcomes, what my patients are telling me they're feeling is improved ability to think clearly. They're using less substances. They're re-engaging with their volunteer work, their part-time employment, they're returning to school, and they sum it all up as I'm able to get my life back on track. So what happened to Tom? So Tom continues on his long-acting injection. He has secured ODSP. He's remained in his housing. He's not had any jail time. He reports to probation regularly. He's only had one admission to the hospital since I met him, and he continues to use meth. And I just wanted to end with these words. Dr. Berrigan, a physician that I used to work with at St. John's Kitchen, always reminded me of them. And this is what I think we've got with when we have so little knowledge of what to do for people with crystal meth, is we do what we can with what we have and where we are.
Thank you so much, Gail. Really appreciate such a great overview of how to address meth using some of the health system processes. It's really, what's the word I'm looking for? It's really gratifying to hear your approach with you, to be so compassionate and thoughtful and thorough in how you treat your patients. I know there are many nurses and physicians like yourself, but we know the medical system as a whole has not caught up with that, and that addiction still gets othered rather than treated as part of health in a more fulsome way. So just thank you for the work you're doing, and thank you very much for sharing your information today. Really appreciate it. So Olivia, just coming back to you, this is a chance for anybody who's attending to ask questions. Please, we've got Brian, Diana, Janet, Gail, everybody's here, and this is a great chance for you to please ask your questions for anything you're curious about or would like to know a little more about. You can either use the chat function, or if you're brave, you're very welcome to unmute and just be a real voice.
There's a question for Gail. Besides helping with sleep, what does mirtazapine help with?
Yeah, so they're studying a lot of different medications. Unfortunately, the medications that we're studying for crystal meth are just more anecdotal. We, drug companies aren't funding any of this, so we don't have those randomized control trials. But one of the things that that mirtazapine is helping people with is getting their sleep back, and then being able to think more clearly, getting their anxiety under control, and then being able to kind of think about whether what changes or where do they want to go with their lives from there.
Anybody else? This is a great chance. You've got some great experts here. If there's something that you would like to know, please don't be shy.
Any burning sensations, but not really burning questions?
Another question for Gail. Do you have suggestions for helping folks experiencing psychosis be encouraged to take meds?
Yeah. I mean, this is always hard. So it's hard because sometimes it's also, I try, that's why I spoke so much about at the beginning, working on the rapport. because it's finding the right time and the right place as well, that the person's ready, that the person recognizes that this is a problem, and then they trust you that you want to help them and you've got something to help them with. Obviously, like for myself, I can't be there all the time with people, so that's where the support workers can really help. You guys have that rapport. I think of you guys like that, like I'm an octopus and you're my tentacles or something. So then I can build on that trust. So you know, if you're working with somebody and they don't usually call their symptoms psychosis, but they'll talk about like the increased anxiety or the not being able to sleep or the just feeling so crazy inside. When they're starting to talk to you about that, you know, if you can tease that out a little bit more and then link them to somebody that you know will help them.
Could I piggyback on that just for a second? Just to add to it, part of what we've also experienced in some of our work around looking at replacement therapies is also, and in medications in general, is it's finding the champions from within the community, finding pharmacies that are going to be able to also offer the support to folks who are using. We have folks that access medications on a daily basis. And to be able to go into a pharmacy and feel that they can go in and get access to their medication, maybe they're not in a great place that day, but still be able to go in and not be exposed to further stigmas, questioning, restrictions. So that has become a barrier for some people. So it's also creating networks of champions that are in the community across the various sectors that we work with, who are going to be able to support folks from a non-judgmental, supportive place to create that safety and not do more harm.
Great. There's a couple more questions coming in. So for anyone, I think could answer this. Do we know how long the withdrawal lasts and what is the full range of withdrawal symptoms?
Yeah, I can answer that. I had this wonderful, I found it on the internet and luckily I copied it. I went to try and enlarge it and everything. But it takes 4 weeks to withdraw off of crystal meth. And each week it's a little bit different. But so I always kind of draw to this this diagram with all the pictures and stuff. But I warn people that the mood changes, that depression that they're feeling, that comes in week 3 and 4, and not to think like, come on now, I've been off this for 2 weeks, I should be feeling better now. So does anybody else want to respond?
I can respond to the whole withdrawal symptoms and stuff like that. So when it comes to me, at least, when it comes to my withdrawal symptoms, the first week I'll be asleep. I would sleep a lot. Like, so right now I'm currently about a week since my last news. I will start drinking a lot of pop, because one of the things I'll try to do is replace, like, my body will naturally try to replace the amphetamines with like replace the uppers with like something sugary, something caffeinated, things like that. Another thing that I noticed, like during week 2, I'll start getting a lot of energy. I'll start getting a natural amount of energy, but I'll be sleeping a lot still. But I'll start getting to a regular routine. And like during the week, the 3rd weeks, 2nd to 3rd week is when I start getting cravings again. So like the first week I won't have much cravings. The second week I'll have like a little bit of cravings, but then the cravings get really bad during the 2nd to 3rd week. And then by the 3rd, 4th week, I'll be like, I'll start feeling like anxiety. I'll start feeling like depression, like a little bit sad. Thankfully, I haven't had any suicidality in the past year, so that's really amazing. And when it comes to like just general feelings of like hopelessness and stuff like that, I can't really say. It's like, unfortunately, my news pattern has gotten to the point where like I'll start using it again just by like the 2nd or 3rd week, just because like it'll help me alleviate those thoughts. I've been trying to talk to my my primary care provider to see if like there's any medications, but unfortunately, because I have no I have no mental illness. I have no prior like diagnoses for any sort of underlying health issues. Other than my HIV, for instance, I don't have any medications that I can interact with. I don't have any SSRIs. I don't have anything like that, antidepressants. So it's more like trying to like ease the cravings through like diet, through exercise, things like that. So that's one of the things when it comes to my withdrawals. I try my best now. Like I've been through a treatment program. I went to Renaissance, which is hands down one of the most best place, one of the an awesome place. And like learn like using those skills as well, like having like ACT training, for instance, like acceptance commitment therapy training, having CBT, cognitive behavioral therapy training, having DBT as well, really helps along with my moods and stuff like that. Even though I'm a trained therapist as well, like I have these techniques for myself. Being a service user actually is really important for me. So like, like instilling some of these skills on people really helps with withdrawals. Instilling some of these skills with people also really helps with like communicating like their needs, and because a lot of times with psychosis, I think there was another question that talked about psychosis for me. I myself don't experience like psychosis, thankfully. Fingers crossed, I don't ever. But I've seen people going through a psychosis, and one of the things I find is that if I coach my friends or the people who use through that sort of psychosis by using like cognitive behavioral therapy techniques, or by using like goal-oriented, like I have motivational interviewing training, so I can use that as well. But trying to get their mindsets around like focusing on their wording, but like maybe directing their thoughts into something else, because they might be because I've noticed a lot during psychosis that that participants or like just the people I'm using with will hone in and focus and like isolate themselves, even though they're in like a group setting already. And then if I try to engage with them, like I'm very cognizant when I'm using, but it's because I've had so much trainings with like certain things. I've had so much like time to sort of incorporate my natural instincts to do stuff with my like when I use. So that's one of the benefits for me. And that's also one of the benefits I've noticed, that with these sort of trainings and with these sort of like outreaches that people are incorporating, the more techniques and the more skills you make normalized in like people's actual lives, like when they're sober and stuff like that, it translates really well even when they're under influence. Because if they have the skills, like they're practicing like daily and stuff like that, or like even weekly, it'll translate into like while they're using, because then they'll be like, oh wait, what do I usually do when I'm not using and stuff like that? Because I'm a regular user, for instance, but someone who isn't a regular user might have sudden psychosis and like they don't know how to handle it. But if you incorporate these skills like as they go, it's really important. It's really beneficial, because it manifests itself even when they're using and stuff like that, which is amazing. When it comes to like screenings for, I noticed that people are sharing chats as well. When it comes to like screening for drugs and stuff like that for the meth, I know urine tests, it shows up like for like 3 to 5 days. For blood samples, it shows up for 10 to 15. In hair samples, it shows up for the next 90 days or something like that. So for when it comes to methamphetamines, at least. So if you took my hair right now, if you took my hair right now and tested it, like most likely my entire hair strand would probably have it. If you took my blood right now, like I'm very open about this, because how Gayle, I've met very compassionate people like that are very the same mindset as Gayle when it comes to the health system. So I've been very blessed by that. But I've also experienced a lot of like discrimination. I've experienced a lot of like prejudice when it comes to my use as well. Because I'll go into the emergency room, I'll tell them like I've been using, so I'm going through like a really acute anxiety attack right now. I just need you guys to be like a little bit compassionate, and they'll just completely brush me off. I've had situations where I tell people that, and they're like, every step of the way, they'll tell me to breathe. They'll be focusing on like making sure that my thoughts aren't going astray, and things like that. Like you get a really mixed bag when it comes to like the health system. But I always try to be mindset of going like, okay, that's fine. I've been using, so like I can't blame them for how they treat me, and I can't blame myself for how I'm treating them. So you know what? Just I always err on the side of kindness, because I always err on the side of, treat people with kindness, because, you never know what people are going through. So like, I don't know how the paramedics days have been going. They might have had like a really crappy experience like the person before. So I'm like, you know what, I don't mind. I've had experiences where like, I literally think I'm having a heart attack. And like, that's like, okay, so maybe I have gone through psychosis. I don't know. But like, I'll have those experiences, but then like the doctors will be like completely brush me off. And then it'll cause me to be very traumatized because it's very difficult, because it's like, oh, that's where the compassion needs to be, like understanding like people who are going through like meth psychosis, or going through like just any sort of like mental health crisis, or just going through like an anxiety attack. It's just the compassionate piece needs to be there, like the kindness needs to be there, because it's just like your feelings are valid. It might not be true, but they're valid. Like it's totally okay for you to feel that way, but let's look towards the truth, sort of thing, or like guiding, or like bringing my attention away from what I'm currently talking about. Like if I'm talking about like my breathing being erratic, maybe making sure that my breathing is like very calmly paced. If I'm talking
So
about like
Brian, can I,
yes,
sorry, but just jumping in a second. I think
but
we're going to ask if you can have that. We're going to take your wonderful words as the way we're going to wrap this up,
yeah,
because we timing wise, we need to do that. But you're treating everybody with kindness is surely definitely a lovely way for us to conclude this series of talks. And I just want to say great big thank you to our 4 presenters today. We just really appreciate your knowledge and how respectful you are, and how you bring your expertise to share with all of us. Also, big thank you to all the people who've attended the sessions. I'm really hoping that you've been able to add to your knowledge and skills. And we've had extremely generous presenters who've offered their contacts, so you have an opportunity to reach out in the future. And we will be sending the slides from today and an evaluation to everybody. We invite you please to give us your feedback. And just wrapping up this series, it's been really awesome. As someone who's been able to attend the series, I've just really appreciated all the wonderful information that has been shared. So with a great big thank you, and wishing everybody really all the best for the holiday season, just to thank you. And we hope that you got really good things from this session for yourself.